Uh, Today we will continue with the remaining part of last day's work on the heart failure. Now this is continuation, and we continue with implantable cardioverter defibrillator or ICD is indicated for all patients with non-ischemic dilated cardiomyopathy, ischemic heart disease at least 40 days post MI, LVEF less than or equal to 35%, history of cardiac arrest or ventricular fibrillation or ventricular tachycardia, life expectancy more than 1 year. Another is the cardiac resynchronization therapy, the CRT, playing a growing role in the management of high frequency REF. CRT addresses the desynchronous contraction that is commonly found in the HF REF by activating the right and left ventricular chambers via a biventricular pacemaker and is at times combined with ICD therapy. Now, anesthetic implications in patients with HF-REF. Invasive monitoring, arterial BP or central pressure monitoring may be indicated. Surgical risk should guide the choice of monitors selected. For low-risk procedures, ambulatory based such as hernia repairs, cystoscopies and cataract surgery, such as hernia repairs, cystoscopies, require no invasive devices. Intermediate to high risk surgery requires more intensive monitoring. Pulmonary artery catheters are not routinely recommended for all HF-REF patients presenting for non-cardiac surgery. Inhalation anesthetics cause a dose-dependent decrease in cardiac output and cardiac contractility. Nitrous oxide, though having the benefit of allowing lower concentration of inhaled agents to be administered, is also associated with myocardial depression in the presence of heart failure, especially when administered with opioids. Nitrous oxide may have a deleterious effect on the pulmonary vascular resistance, causing an increase in the right atrial pressure, secondary to sympathetic stimulation. Heart failure with normal ejection fraction. Approximately 50% of HF patients have poor systolic function. The rest of the patients presenting with HF will have what is known as HFnEF. These patients are likely to be older women with hypertension. Symptoms and signs. Clinical signs consistent with HF as mentioned previously, notably shortness of breath, preserved ejection fraction on echocardiographic examination, increased filling pressures and impaired left ventricular filling. Pathophysiology of HFnEF. Patients with HFnEF have a normal ejection fraction but have diastolic dysfunction. A hallmark of HFnEF. Diastolic dysfunction is a result of both impaired relaxation and increased left ventricular passive stiffness, and may be part of the normal aging process. Impaired relaxation is likely due to ineffective calcium removal from the cytosol, resulting in a slow LV isovolumic relaxation phase, which is worsened by myocardial ischemia. The net result of the impaired relaxation and increased stiffness is an elevated left ventricular end diastolic pressure, which can translate to an increase in the left atrial pressure, as well as pulmonary capillary pressure. In HFnEF, an increase in the blood volume coupled with tachycardia-induced decreased diastolic failing time can cause dyspnea on exertion and pulmonary edema seen in response to exercise. Non-compliant LV is unable to accept more preload and thus is unable to use the Frank-Starling mechanism to augment the stroke volume. This much for today. We will continue with the remaining part next day. Thank you.